Now we have Dr. Shilpi Mohan to talk about. I would reveal the pros and cons. Over to Dr. Shilpi Mohan. She's from Hyderabad.
Good afternoon, everyone. I'll not keep you away from your lunch for a long period of time. First of all, I'd like to thank Dr. Kamal Sharma for giving me the opportunity to bring forth my views on ivabradine in acute heart failure situation in the backdrop of the given case. So there are three pertinent questions. Can ivabradine be given in acute decompensated heart failure? How to titrate the dose? And can it be combined with beta blockers? As we all know that in a chronic heart failure situation, we have plethora of evidence, be it Signify trial, SHIFT trial, Beautify trial. But as compared to the chronic situation, acute heart failure situation, we have very limited data. But it is worth considering because it is one drug which has got no negative inotropic effect. It is devoid of any effect on neurohormonal system, which makes it very important in a situation when we are dealing with acute heart failure situation, where we have to give benefit to the patient by reducing the heart rate. Before summarizing how to deal with such a situation, I would like to bring forth this 2024 meta-analysis of 10 studies in acute heart failure situation, which concludes that ivabradine can reduce heart failure. This reduce heart rate. It can reduce NT-proBNP levels, elevate ejection fraction, 6-minute walk test, with no impact on CV death, mortality, and rehospitalization. So we have certain this thing, not exactly benefits that we don't get CV benefit, mortality, and reduction in the rehospitalization. But it definitely helps in reducing the heart rate, NT-proBNP levels, which we were discussing earlier, and elevate the ejection fraction in 6 minutes walk test. So the current recommendation in this situation is beta blocker remains the first line therapy. Ivabradine can be used along with beta blockers where beta blocker is contraindicated or poorly tolerated. We do not formally recommend ivabradine initiation during acute heart failure situation as the first line. First line is beta blocker. On top of it, we can add ivabradine. Now comes the next question. How high can we go with heart rate reduction? When we deal with a stable heart failure situation like ejection fraction less than 35%, with resting heart rate more than 70 beats per minute, how should we start the therapy? We should first of all start with 5 milligram twice daily therapy, and then we can titrate, up titrate or down titrate according to the requirement. Maximum dose initially was 10, recommended was 10 milligram twice daily, but now it is 7.5 milligram twice daily, representing the upper limit of safe titration. So what do we want to achieve? We want to achieve a stable heart rate of 65 beats per minute, and that may be an appropriate therapeutic goal for patients with heart failure with reduced ejection fraction. And how to titrate? If the heart rate goes less than 55 beats per minute or the patient develops symptoms of bradycardia, we need to reduce it by 2.5. If it is maintaining at 55 to 65, we can maintain at the current dose. If the heart rate is going more than 65, then we can add dose of 2.5 up to 7.5 twice daily and monitor the heart rate until the heart rate is stabilized. And as we all know, heart rate stabilization is very important in acute heart failure situation. So the current recommendation is we need to closely monitor throughout titration to avoid to get maximum heart rate titration and to avoid bradycardia related side effects along with atrial fibrillation and other side effects which we can see with ivabradine. Now comes the third question: can we combine ivabradine with beta blockers? Yes, we can definitely combine ivabradine with beta blocker because both of them have different pathways and they allow safe and synergistic heart rate control. Both of them provide complementary and synergistic benefit in heart failure with reduced ejection fraction by improving the cardiac output, preventing cardiac fibrosis, then improving cardiac function, improving endothelial function, biocardial perfusion, coronary blood flow, and improving the stroke volume. So how can we combine ivabradine with beta blocker? Patients who fail to achieve a significant reduction in heart rate with beta blocker, or those who are not able to tolerate the beta blockers, like their exercise capacity is reduced, or those who are intolerant to high dose of beta blockers, this becomes an ideal candidate for ivabradine. ESC Heart Failure Association Consensus 2025 suggests that ivabradine can be particularly beneficial in such patients where low BP limits optimization or escalation of beta blocker, as I already mentioned. And it can enable both effective and beta blocker management over time. And if beta blocker is not well tolerated hemodynamically, ivabradine may be a viable alternative option, either alone or combining with beta blocker, as it helps facilitating its titration, and both can complement each other. Thank you for your